Good afternoon, everyone. I think some of those questions following the last panel were a perfect tee-up for this discussion, so really appreciate that folks are following the agenda and anticipating this next sector discussion. So welcome to our second panel discussion, where we'll turn to the role of the private sector to examine what it does and what it can do to improve access to behavioral health services. And this is really important, as we heard earlier. It's important for our country, it's important for our communities, our workforce, and just to give some statistics on all three of those points, 1/3 of Americans in our country, 160 million, live in a designated mental health professional shortage area. As far as our communities, 77% of our communities report severe shortages of psychiatry. As far as our workforce, 86% of employers list mental health as a top concern. That's why we're here today. Not only does the Chamber focus on our country and our communities, but also on our workforce. And so I'm thrilled to have our panelists here today to talk about private sector and the role that they can play both in helping with mental health and in interfacing with CCBHCs. In this session, we'll explore how the private sector can and does drive change by partnering with certified community behavioral health centers and other stakeholders within workforces and communities. My name is Katie Mahoney. I'm Vice President of Health Policy here at the U.S. Chamber of Commerce, and we're really thrilled that you're here for this very important conversation. Join me in welcoming our four panelists here, Susan Ellender, Eric Paul, Kevin Scalia, and David Theogold. To kick off the panel, I'll start with some questions for each of the panelists to give them a little bit of an opportunity to talk about their organization and the role that they play in it. Susan, from your perspective as a benefit consulting firm, you've worked with businesses of varying sizes. Over the years, I know you've been focused on improving health insurance access and coverage, particularly for small businesses. How has the importance for providing access to meaningful behavioral health evolved, particularly for small business?
Thank you, Katie, and thanks for having me here, everybody. I can't tell you how enjoyable this has already been and how much I've learned that I can't wait to take back to the chambers and the membership organizations that we work with and the private companies. Because as we all heard earlier, as the overall basic health of people goes, so does the well-being of our families, our businesses, and the other organizations that our society depends on. And so the innovation that we've seen from employers requesting it and being louder and louder in their cry for help for their employees, particularly in small businesses. Just, as Kevin, right? As Kevin said, small businesses are families. They're owned by families. Their employees become family members. And we want to help them. Members associations, chambers of commerce, they worry about their employer groups and their employees. So we have seen some vast innovation from digital tools, bringing apps to individual employees so they don't have to go to the HR person who is also most likely their boss or the owner of the company. If you're talking to 6, 7 employees, they don't feel comfortable going to them and saying, hey, I need help. So they have digital tools that they can do this anonymously and they can get help, whether that's in person or it's a recurring appointment with the same therapist via telehealth. We've seen that. We've seen innovation in private companies through grants, through different departments of the government that say, this is for small business to help financially incentivize employees to do health productive activities, mental health, physical health, holistic health, to make positive impacts across their lives and the lives of everyone in their community.
Thank you. And Eric, HCA Healthcare is an extensive network. We all know the organization pretty well. Over 2,000 sites of care across 21 states. And the behavioral health system is, in particular, quite significant as well, with 61 inpatient programs, 160 outpatient programs across 17 states, interfacing with over 1,100 patients a day. How have things changed over the past 3 years in terms of reaching and supporting patients?
Well, first of all, Katie, thanks for the opportunity to be a part of the panel and present about HCA. But, take a step back. We have 183 hospitals across 20 states. In 2022, we saw over 400,000 patients in our emergency rooms that had a discharge diagnosis of behavioral health or substance abuse. We admit on our inpatient acute behavioral health beds, we do about 120 to 125,000 admissions a year. So you can see there's a deficit there. We see 400 in our ERs, admit 120. So there's a challenge for us for that balance, right? That 280,000 patients. One of our biggest opportunities and why I think this is important to talk about our relationships with CCBHCs is because we make a lot of referrals across our enterprise to organizations that have the ability to take care of patients, regardless of their financial means, regardless of their situation, if it's a child, adolescent, adult, or even geriatric. So we see a lot of patients, and when you think about the number of patients sitting in our med-surg beds, on any given day, we see about 35,000 patients a day. And when you look at the percentage of those patients that have a morbid condition or co-occurring condition, it's about 28%. So if you do the math, that's another 10,000 patients a day that really have a need for mental health services. So we believe at HCA that mental health is healthcare. You can't have physical health without positive mental health services. So we're in the business and we're committed. And I think, Katie, we're committed to the degree that we're also on a very expansive expansion. We see in our top 35 markets a need to expand probably between 12 and 15 additional freestanding behavioral health hospitals just to meet the demand that we've seen over the last 3 years.
Thank you. And the last two speakers, I think, were already kind of chomping at the bit, given one of the questions that was posed earlier. Kevin, with NetSmart's focus on health information technology, we see how care coordination is a vital component of behavioral health care. How does NetSmart help improve care delivery and facilitate outcomes-based services with your clients in terms of promoting access?
Well, thank you also for inviting us. About 45% of all the CCBHCs in the country use our technology to run their business. In behavioral health, if you look at healthcare in general, the IT that we use when you go to a hospital, your primary care doc, there was legislation passed about 10 years ago called the High-Tech Act that provided about $30 billion in funding for hospitals and for primary care docs and others to implement the technology to provide integrated healthcare. Behavioral health providers, for the most part, were cut out of any of that funding. So they've lagged behind the ability of all other providers to integrate. And to Eric's point, the brain is the biggest organ in the body. And if we're going to address a person's healthcare, you have to connect the brain back to the body. So we've spent a lot of time focusing on how do we connect behavioral health providers with the physical health providers who are treating those clients. And I'll comment on some of Brent's work. I think he's a little humble in saying that they've done a good job. They're basically the grandparents of the CCBHC program, where they have integrated every community mental health center in their state into a population health system that shares data, benchmarks the organization so they can share best practices across those organizations, and then have the state have visibility into it too, so you don't have to build another system. It's game changing, and by doing that, they've reduced the use of the emergency departments in the state by 57%, very similar to what Melissa said. But from a financial point of view, so that's a great outcome for the patient. They've saved the state almost $350 million in the last 5 years by coordinating care. So there's a huge ROI to the payer for the care by having these tools. And as Chuck said, the CCBHC program for the first time has the ability to build in funding to help subsidize the implementation of the tools that this community needs to integrate with the physical health community.
Thank you. And to round off our panel, I know David, Genoa Healthcare is a pretty interesting organization, and your role there has focused on telepsychiatry. Can you talk a little bit about how telepsychiatry has grown within the areas that you serve, and in particular improved access and overall experience over the past 3 years?
Happy to, Katie. Just give a little context. So I'm first and foremost a mental health advocate and family member. My mom had schizophrenia. I served on the National Board of Mental Health America right nearby here for 10 years, and I got to know, Brent, I recognize you, and I got to know a lot of the folks in the behavioral health space with the National Council. So I first want to just thank the National Council because they have been so instrumental in making CCBHCs successful, and it really has been transformational as a mental health advocate. When I first started, people were so suspicious this would go anywhere, and it really has. And that's part of the reason why, just to pivot, while I ended up where I did, I have and I should also just say as a connection to the Chamber, so my background originally was in business. I'm a Harvard MBA, so I'm in the temple of business right here at the Chamber. That's great. But to see it tie together with my passion, my cause of community mental health is really meaningful for me. And I'll give you just some examples of what we do at Genoa Healthcare. Genoa Telepsychiatry is part of Genoa Healthcare, which has on-site pharmacies at community mental health centers. We're ultimately owned by Optum and United Health Group. United Health Group is here as well. Thank you, Kate. And what we do, we're kind of the cutting edge of I'd say, the corporation addressing the workforce challenges in community health. What we do is, it's not just about making it easier for psychiatrists to practice in other parts of the country. It's making it easier for them to practice, period. So whether it's because they can retire and work longer up until, their 80s, or they have to take time out because they have a child, or to care for an aging parent, or problems with kids. These things happen, and yet it's much more feasible to continue to practice. The other thing I'd say is that we get more doctors who work in community health. Oftentimes, that's why they started in the profession. And when they took that Hippocratic Oath, they really want to serve the underserved. And it's hard in practice, not just geography, but salaries and coordinating with spouse, where you're going to live, et cetera. It makes it easier to work in community health. So I think we have more docs practicing psychiatry and more working in community health centers. So that's what we're about. To give a little bit of scale, we now serve almost 200 community health centers. Almost half the doctors we employ are working at agencies that are CCBHCs or have received CCBHC funding. So it is big, as our previous speakers mentioned, just the increase in the workforce of well-funded positions. We see that. So it wouldn't have been possible without CCBHC funding. The other point I'll make about what we do that's improving, we like to think it's improving the healthcare system, is we also bring a greater diversity of providers. Particularly if you look at psychiatric mental health nurse practitioners, but even with psychiatrists too, there is a far greater percentage who are female, African American, Hispanic, immigrants. It's wonderful. It matches the population of the people that our agencies serve. So that's a big benefit as well. So I'll pause there. Thank you.
Great, thank you. The gaps that we see in mental health services are profound. We've talked about that all afternoon, and multifaceted. They span workforce issues in terms of retiring providers, challenges in terms of educating new providers, Some alarming statistics I'll share with you. We've heard several of them already. 70% of practicing psychiatrists are over 50 years old. And we understand that without an influx of psychiatric students, the demand for psychiatrists will outstrip supply by 25% in 2025. We've also heard that there are lots of opportunities for improvement here. And one thing I'd really like to explore is we heard about how the CCBHC model allows for standardization, but that it also allows for localization in terms of drilling down at the community level and reaching different populations, how and where they need to be reached. I wonder if you could, we'll start with Eric, maybe talk about how your respective companies have interfaced with different CCBHCs around the country in different ways, potentially in terms of emergency room and presentations there in rural areas versus urban areas.
Yeah, thank you, Katie. I'll answer it in three ways because I think it is important. HCA, from a psychiatry perspective, we actually are the largest educator of psychiatrists in the United States. We have 14 GME programs, and then we have additional 2 fellowship programs. We also were fortunate enough to be able to acquire a School of Nursing, Galen School of Nursing, based in Louisville, Kentucky. And we're trying to work, create these dedicated educational programs where we can partner with schools of social work or professional counseling because we have a need for therapists, right? Therapists, if they want to go on and become licensed and credentialed, they need to have 3,000 hours. So from my perspective, my chair, it's a kind of a win-win-win situation. But specifically, Katie, to working with community CCBCs in the ER, across the states where we have mental health units, but also across the entire enterprise where we have an emergency room. Because we have 183 hospitals, we have another 125 freestanding EDs, and probably another 200 urgent care clinics that are all access points for mental health services. We are the safety net in a lot of situations. So we work closely with community mental health centers. We have worked with, I'm from Nashville, Tennessee, so Mental Health Co-op is one that comes to mind where they've actually work in our ERs, but they're not alone. We work with Grace Point or PIMS in Florida, since I know we have some folks from Florida. We have provided them with technology, right? So to be able to function and do an assessment for our patients. We have community mental health centers that are a part of our treatment planning process and really integrate into our treatment teams because, again, looking at some of the people that are uninsured or underinsured, it's difficult to find counseling placement. So we work effectively with them to meet those needs, but it's also a challenge for those patients that even have insurance, right? Because, we're required to provide, a discharge appointment that is seen within so many days, right? And so, we struggle getting an appointment within 7 days, within 14 days, and within 30 days, even if they have insurance, because I think as the previous panel said, I get asked a lot about who can I refer an employee to, an employee family member to, who do you know in Nashville, who do you know in Tampa, who do you know in Dallas, Texas, that, I have a family, friend, loved one that needs mental health services, and the wait list is 6-8 weeks. So I think being able to partner with organizations like the CCBHCs help us tremendously, right? I still, when you think about numbers in 2022, our behavioral health hold times in the emergency room went up by 12%. This year, just 2 months into it, it's up an additional 9%. And so the demand is there, right? It's just access is the challenge, and I don't think it's access as far as, I think it's more of an in-network issue, but the CCBHCs give us greater access.
And Kevin, I know that your work in technology and the work that you do with CCBHCs is certainly very future forward and thinking about how that might evolve in the next 20 years. AI has been a conversation with regard to a lot of different workforce challenges. How do you see that playing out in terms of the work that you do?
Well, we're doing it today. If you, I think it was Melissa talked about, we're probably not going to get any more people. So how do we do more with the people we have? So I'll give an example. We have a progress note tool that helps, you kind of put scratch notes down. It generates a progress note. And to Chuck's comment before about, it actually looks to make it compliant with regulatory requirements. Like if I transported Chuck to the emergency room, I don't get paid for it. If I accompanied him to the emergency room, I do get paid for it. So it helps look for those type of things. But from a clinician point of view, it's probably the most dreaded thing that clinicians have to do. They don't do it timely because it is a dreaded thing. They end up doing it at night and may not be that accurate. So if we can build it right into the workflow, that's something that's really important. We're also using AI on the payment side. As we deal with hundreds of different payers, many of our clients have literally hundreds of payers, all with different billing and reporting requirements. How do you automate that and take that rote, mundane stuff that everybody hates to do and let a robot do that? And so those are two of the biggest areas that we're looking at now. And we're looking at now we're actually doing some pilots around suicidality. Can you use the data to identify somebody who may be becoming suicidal so you can take some action a priori before something bad happens?
And I would be remiss if I didn't ask David to please speak to that as well in terms of AI and telepsychiatry. David, how do you see that evolving in the future?
Sure. First of all, Kevin, I have to say that one of the single biggest problems that I've dealt with, and a lot of my work is interfacing with our clinics on workflow with the agencies, and one of the biggest pain points is our docs are not getting their documentation done in a timely manner, or they complain and it's so difficult to do. And so anything you can do to improve that would make our life a lot easier.
We often joke, even though we're in the EHR business, not one clinician ever went to school saying, man, I wish I could spend my day in an EHR.
So, to answer your question, Katie, I think, truthfully, that is our biggest challenge with technology. It's the EHR. To correct a misperception, telepsychiatry is not about the technology. It's about psychiatrists, the people that we bring to the client in a more accessible way. But we never talk about our technology. We talk about our providers. And the providers use the technology of the clinic, which is an EHR or a secure messaging service, what have you. And then I guess I can share the experience of our providers is that they do use, in terms of technology, sometimes gene marking services, which you will come across. That can be helpful. I haven't heard of any really serious about using AI to diagnose. Haven't come across that in a serious way.
And I know that Genoa does a lot of work in terms of pharmacy work, and so I was thinking in terms of the AI work there, and prescribing and automating that a little bit more.
Sure, that's very true with pharmacy.
Well, I'd love to hear a little bit about what you're doing for your own workforce. As we've talked about, the Chamber's been very focused. As you walk around the organization, you may see different signs that talk about the wellness offerings that we have for our employees, whether it's physical health or opportunities to improve exercise that often helps with mental health issues as well, or behavioral health issues in terms of getting more endorphins and other things. And I would love to hear kind of what you all are focused on in terms of workforce challenges, particularly for those that we hear are really seeing tremendous burnout 3 years into this, towards the end of this, wrapping up this pandemic, and sort of what supports you all have offered either to the small businesses that you serve or to the workforces that help you serve your clients.
I mean, I can talk. I think one issue that we deal with is I've been CEO of 3 different companies. Never had anybody in my company ever really approach me about a mental health issue till I came to NetSmart. And I do a lot of our strategy work, and I educate our company on what is going on in the marketplace. And all of a sudden, I would get people coming up to me and saying, my son has an addiction problem, but I have no idea who to call. If I was having a heart attack or have a heart problem, everybody knows a cardiologist or an endocrinologist or an internal GI guy, and they can make a referral. Very few people know, hey, my son is hearing voices. Oh, I'm going to refer Dr. Theobald. He's the guy you should go see because my other friends have seen him. So getting awareness out there, which I think you're seeing some of the stigma first come down, and then letting people feel good that it's okay to do it. Our company, because we're in the behavioral health business, Chuck mentioned mental health first aid. More than half of our 3,000 employees are have been through the mental health first aid process. So you have a natural discussion. I highly recommend all businesses that are in the chamber go through the mental health first aid process because it makes people aware of what to look for. And to ask, don't be afraid. Well, he's looking a little depressed today. Confront them, ask them, talk to them about it, and you'd be surprised the reactions you get. That's one we use, and we do use, I can't remember, I was trying to remember the name of the app that we have on our benefit plan. Melissa mentioned Calm. We have something like that a lot of our clients are using too.
I'd like to add to that as well. I think it's about education. It's education to the businesses and the businesses to their own employees of what services are there and truly what services they're already offering. I mean, it's amazing how many employers have an employee assistance plan, and employees may not even know that. It's not reminded because, particularly in small businesses, like I mentioned before, that HR person is wearing so many different hats, and it's repetition and repetition, and I do agree that the stigma is being reduced. It's still there. We have a long way to go, and there's a continuum of well-being to be done. But we need to educate. What we do at Associated Benefits is we have forced vacation. You have to take at least 5 full days away from the office. You don't accept emails. Your cell phone's off. And I am a huge proponent of that. We're all working 24/7. We all have our phones by us. You got to step away, and that is part of your mental health improvement. So that's a little something that we do amongst some other things.
One thing I've noticed at the chamber is we have new kind of AI functions on our email. And so as I was sending out an email tonight to our team here that's helped with this event on Friday at 5:15, it said, would you like to send this maybe on Monday at 9? Yes. So I think it's really, that speaks to sort of, I think, what our organization and many others are looking to try to do for their workers.
So, Katie, from an HCA perspective, we have about 300,000 employees across the enterprise. So we think we're doing a lot, but probably there's still a lot more that we are not doing. We obviously have through Optum our employee wellness program for all employees, but we've identified that our nursing staff needs a more customized approach because it's inherent within their profession. So we also make available to all of our nurses, which I think there's close to 40,000 nurses in the system that have access to a specialized platform just for nurses, so they can speak to a nurse, kind of peer-to-peer type situation. We have published a podcast in conjunction with Columbia University and an organization called PsychHub, where we make available to all of our employees. We've designed programs specifically for our physicians because of the burnout situation. We are a member of Mental Health at Work, which is an alliance of some of the larger employers in the United States. And I think, as others said, it's also a constant communication to our employees that resources are available to them. And then we also, as at the service line, will deploy our therapists if there is a crisis in a hospital situation or a market where we have community hospitals. So could we be doing more? I think so. We have, because of the 300,000 employees, it's a very complex organization, and we have different groups. Mental Health Ally is a certificate program that some of our divisions require the supervisors to take. Love to be able to deploy that across the entire enterprise, but I think it's just a matter of chipping away, if you will, at some of those obstacles. But it's a, burnout, stress, anxiety is a problem that we're dealing with on a daily basis.
Thanks. I'll just add one thing to help address the provider burnout that we found is we really focus on making sure our psychiatrists are embedded in the care teams of the clinics where they work, so they can share the stressors of challenging cases with fellow team members, and also participate in peer reviews where they're speaking with their peers on more clinical approaches. We do some of that internally across our company, but it's most critical just to have them engaged with the other clinicians who are serving the population.
In terms of recent legislation, we're here in DC in the nation's capital. A couple of things come to mind in terms of the panelists here. I know that there's been some recent changes to a section of the Federal Register that's affectionately or not affectionately called 42 CFR Part 2 in terms of substance use disorder and the ability for individuals to make sure that their histories of substance use disorder is in their electronic medical record. Wonder if you all might want to speak to that, Kevin, and then secondarily, challenges with regard to telehealth, particularly during the pandemic, with being able to see your provider when you're, virtually when you're in your home, but perhaps you go to visit your sister and you're across state lines and you can no longer turn on the same laptop and see the same provider because of where you're across town. So interested in those perspectives.
Yeah, so I've been very involved with Chuck and others in changes to 42 CFR over the last 10 or 15 years, and we've made tremendous progress. Back probably almost 10 years ago, SAMHSA tried to do a pilot with 5 state HIEs and how we could transmit protected data for somebody with a substance use diagnosis. And the cost of the HIEs to modify it to meet some of those requirements were so much that they all opted out and said, the simplest thing to do is if you have a substance use diagnosis, we're not going to accept your data. And so I felt, and many of us felt that was discriminatory to people with a substance use disorder, because if I have diabetes, I can share my data and get all the better care that would come from associated with that. So over the last 10 years, we've done several updates to 42 CFR that have made, very much easier for us to share data, especially with a primary care doc or an acute care hospital that really doesn't think about it the way most behavioral health and substance use providers do. My concern with the most recent NPRM that we just submitted comments on about a month ago is that there's some components in there. The way technically we send data through an HIE, it may make 4 or 5 hops through different HIEs to get to the end user. And I can give you an accounting of everybody I've sent data to, and the recipient can too. The way the current one was written would make each of those hops have to be able to do that reporting. Well, none of that infrastructure has the ability to take calls from consumers to ask for data. And even if they could, the data they would get back would be unintelligible. So that is one we submitted a lot of comments on. Don't make those intermediaries subject to the rule. They're carving the EHR vendors in to be an intermediary. I'm fine with that. The providers are intermediaries. That's clear. Don't make the plumbing in the middle part of it, because they'll just do the exact same thing. Okay, well, if we're subject to that, we're out.
Thank you.
And just another perspective is, fortunately, most of the individual states prior to the public health emergency had already made progress liberalizing telehealth in terms of the location of the provider and the client. And so that was less of an issue, fortunately. So coming off the public health emergency, it won't change that much. At the federal level with Medicare, there's a requirement that's being discussed, and I know Chuck's team's working on it, that a client would need to come in every 6 months for an in-person visit. That would pose problems for a lot of clinics and a lot other parts of the country. And I'm going to give one example. I work in California. We have a big community health center, also FQHC, called Imperial County Behavioral Health. There are they have no in-person psychiatrists across the county, not one. So and we serve them with 4 remote. So there's just no way they can comply with that. So both with the National Council and with the California Behavioral Health Association, we're sharing our concerns about that one requirement that was added.
And in the private insurance market, it's complicated as well.
We hope so.
I have 3 teenagers. I feel like, with full disclosure, right, we're up here sharing our various family personal experiences. So 3 teenagers. I know well that, you know, the challenges with private insurance and accessing telepsychiatry can be difficult. So.
Yeah, you know, Katie, from a telehealth perspective, so we launched our own telehealth business probably in October of 2019. Got lucky, if you will, because of the pandemic. We were able to use that technology and flip it to use it for outpatient services, because we see on average about 220,000 outpatient visits a year, you know, structured programs, the IOP and PHP programs. And, you know, during 21 and 22, you know, we probably had close to 35% of our patients accessing services via telehealth services, right? Some of our hospitals are in more rural areas, so it provided much greater reach. You know, as of February, we still had about 11% of our patients accessing outpatient services via telehealth, and so it's going to be a struggle for us come May when the PHE expires, because we are, you know, hospital-based, aren't going to be able to offer telehealth services. So, you know, that's a challenge for us. I think it's a, you know, disservice to the people that are accessing those services via telehealth, but it is what it is. So it's going to be difficult for us to be able to ensure continuity of care for that 11%. So it is a challenge.
We've talked a little bit about recent legislation and challenges in terms of regulatory issues and licensing issues. What do you think has been the biggest improvement during the pandemic in terms of access to mental health or reduced stigma on mental health? I know that the numbers have really skyrocketed in terms of particularly our youth and the difficulties in what the lockdowns meant for them and the isolation meant for them. But I think that there's been a lot of silver linings that have come out of this in terms of rocket acceleration with telepsychiatry, at least from what I've seen in terms of as a consumer and with our member companies, as well as with just sort of the recognition of how difficult the past 3 years have been on different elements of our communities. So would love to hear sort of big, small, what's been the kind of greatest silver lining that you've seen. And you know, you all come from different parts of the country. Here in DC, I think it's pretty remarkable to walk around and see almost every block has at least one empty storefront. And so just interested to hear in your communities sort of how that also is translating.
Well, I'll start. So I think it's the greatest thing, silver lining, if you will, is the flexibility that the federal and state governments has allowed us as providers. I think even from an employee perspective, Katie, you know, I sit on the employee benefit committee, and we went to telehealth for our employees organization, and we're seeing a huge increase in our employees and our beneficiaries accessing telehealth services, you know, physician on call, teledoc, whatever the organization is. I think allowing telehealth services to cross state lines has been very beneficial for us, especially where there's a shortage of psychiatrists. We've been able to use telehealth for inpatient admission and inpatient rounding. We use them for, you know, on the outpatient side when a patient has to be seen weekly, where there's, you know, a shortage of psychiatrists. So that's helped us being able to really offer behavioral health services remotely. I know that's going to come to an end, but that's been a significant advantage to us. So To me, those are the things that are, have provided the greatest opportunity, is to be able to realize that, especially mental health, I think, people are comfortable accessing services remotely through telehealth, and I think it's something that really is going to, be on the, become the norm, if you will.
I would agree totally. With, if someone has anxiety, just the thought of going to sit in a therapist office or wait in the lobby can be a deterrent to care. We have worked with a company named Impact Suite, and they have done amazing work in the digital space throughout COVID, especially for parents, and bringing awareness of different social medias and how those can negatively affect their children and the youth. So I think that's been remarkable, and has brought these tools to a lot of individuals and have helped. So that, and I think at the same time lowering the stigma that comes with it.
I would echo everything that Eric just said. We certainly saw our telehealth usage, go up 20-fold. The other part is that's consumer-facing, is provider-facing, that a lot of the providers all had their clinicians remote. And so how do you expose the technology you have inside your business to clinicians who are now working at home or working remote, giving them access to the EHR, the population health tools, whatever you had? I would say that one, and then also providers looking to, we have a consumer portal. We can go in and access your record. It was something that most clients were hardly using. They met a MIPS reporting requirement with it. But now everybody's looking at, I want to be able to push assessments out. I want to do check-ins through that. I want to automate a lot of things that have been manual before. So from a product point of view, those would be 2 or 3 of the biggest areas we've seen.
I would add that initially with COVID, there was a spike in acceptance of telehealth, both from providers and consumers. Hey, this works. It's so darn convenient. And the provider agencies figured out pretty quickly that, wow, the no-shows dropped dramatically, so the economics are much better now. So that was a big one. But I would caution it with, at the same time, there is a need for clients to engage in person, and our model and with how generative telepsychiatry works and how CCBHCs and community mental health centers work is they have the ability to reach clients, whether in-home or have them come into the clinic. And we actually work with a couple assertive community treatment programs now around the country, and that's really neat because the providers going out, whether it's under a bridge or in a residence, but you don't need the client to come into the clinic, but you do need some in-person touch points. And that's important to keep going. Even though there's a shortage of psychiatrists, and there's a shortage increasingly of therapists and caseworkers too. There's usually some staff member, and it gets into discussion on licensing, as long as we can get reimbursement, and it can be a peer. There's an explosion of peer workers that is a wonderful and important piece of the solution. But to get somebody who's still engaging in person with the client's important.
It's interesting. There's been a lot of different analysis about and questions, frankly, from the former Secretary of the Department of Labor, for one in particular, about the efficacy and the longevity in terms of the outcomes for telepsychiatry, et cetera, and particularly with regard to substance use disorder, and is that really an efficient and effective, more importantly effective, modality for that type of treatment? And there's also been a lot of analysis done by employers in terms of looking at the benefits for people to come into the office. And so I think that's sort of an interesting parallel in terms of improving access, reducing the barriers, physical or otherwise, to getting that access to services, but also on the same side recognizing that we are human beings and interaction is important. So thank you for that. I guess I'd love to hear, Susan, a little bit more about, in the state of Louisiana, where you are, small businesses seem to have buoyed the pandemic quite a bit in terms of many of them have been the ones that were the first, the last to leave and the first to come back in terms of workforce. So interested to hear what challenges they may have in terms of the benefits that you offer them and or help them find.
Well, I think, looking at Louisiana specifically, we've had in the last 3 years, not just the pandemic, but we've also had 2 major hurricanes that have hit our state. And we have workforce huge issues of people being displaced. We have issues of people fighting with their property and casualty insurance companies, their absenteeism, their presenteeism, et cetera. And so we have worked with the Louisiana Association of Business and Industry to roll out the benefit center and say, hey, there's an individual EAP. You can buy that, John Doe as a member, as an employee of this benefit. We're working with new innovative companies to say, employers, you can financially incentivize your employees. We are trying to help them in all aspects of that in the mental health arena because we have had so much. We've lost, workers across the board. The number of employees that frankly were so displaced, they didn't, whether it was the pandemic, in addition to the hurricanes and being the physical devastation.
Any other anecdotes in terms of locations where you all are located and sort of how things are emerging in your areas of the woods?
No, keep going. Yeah.
Just in terms of return to work, what you're seeing with the changes in how folks are accessing services with.
Oh, yeah, I'll just comment on one thing is that in a workplace, like our own workplace and at Genoa and United, all the way up through United Health Group they've pretty much blown up the offices, best I can tell, There's far fewer of them. And so a challenge is frankly, especially for young people in the workforce, I imagine it's across, the chamber's members, is when you hire young people, I have a daughter entering the workforce, it's like, how does she bond with everybody if she's remote, so that is a challenge, I think. How does she identify with the employer? So it's something we're trying to figure out. When you serve a greater mission like community health, that kind of binds you. So we bond with our clinics. But how do the employees bond? That's harder.
Thanks. Kevin, as one of the first people that I talked to when we were putting this event together, I'd like to give you the last word before we turn it over for
ours is, we've done the same thing. We've blown up a number of offices, but, and I'll give 2 examples. The stuff we're doing is we're developing a new product that's extremely collaborative. You have to be in the room. People are writing on a whiteboard. So we were, as you said, we were one of the last ones to go out, and brought the offices back very early because we think it's important to our culture to have everybody there. But my son, who graduated a few years ago, worked at Northwell Health in New York he was there 3 months before they shut the hospital down. And he worked from home, so he's never been in an office. And I have the same conversation. And when we sit around the table doing promotions and other things in the company, you see names you've never met before, where I used to see them in the cafeteria or the coffee machine and talk to them about what they're doing. We would do trips together or something. So I think it's going to have to come back because you're going to get to a point where how do you promote people if you don't know who they are? Can they lead other people? You just don't see that.
Well, I'll remember today because today was the first day that my entire family was out of the house since the pandemic started. So on that note, thank you very much.